Thanks to the so-called pain revolution, we no longer perceive pain and nociception to be alike. However, through the years, this idea of nociception not being equal to or necessary for pain has led the focus away from the value of understanding how nociception does relate to pain. I admit that I've been biased to believe that neuroscience rather than anatomy and biomechanics seems like the most relevant place to look for scientific understanding of pain. And over the years, I've come to understand pain as well as nociception through the eyes of a clinical pain scientist. But let me give you a few examples. During most episodes of acute pain, I find it difficult to believe that nociception is not involved as a primary player in the experience of pain. My basis for this view is the fact that in my studies, I can make most people feel pain if I stimulate them with enough intensity. In a clinic, I see patients with acute onset of pain that more often than not are localized and can be reproduced by pressure or other mechanical stimuli to the tissues. I do realize the limitations of these observations and also of the scientific methods used to falsify them. So if you don't agree with me, that's fine. So let me give you a clinical example of how we can use the biological principles of nociception in the clinic. My first example is the role of nociception in what we refer to as peripheral sensitization in acute painful experiences. I was taught to spot pain patterns when I was training as a manual therapist, and I would call these patterns mechanical or ischemic or inflammatory pain, which I, at the time, thought was very intuitive and I felt it was right. Yet, when I review these with the eyes of a neuroscientist, they convey little, if any, information about the mechanism behind the pain and how I should deal with them. When palpation, stretching, or even movement provokes the patient's known pain, we refer to this as hypoalgesia. Most pain scientists believe that localized or primary hypoalgesia, as we call it, can be related to a phenomenon known as peripheral sensitization. Peripheral sensitization shares many features with its much more known relative, the central sensitization, which I will mention later. The most likely cause of peripheral sensitization is an inflammatory process, which can be caused either by tissue damage, such as fractures, or pathologies such as cancer, or from a normal response from the so-called peptidogic C fibers in the tissues. We refer to this as neurogenic inflammation, and in fact, peripheral sensitization is the ideal candidate for a mechanism to explain how repeated movements can hurt and then stop hurting after a day or so. I would say much more ideal than any biomechanical explanation. In the clinic, I test for hypoalgesia and look for possible links to peripheral sensitization by completing a thorough interview and subjective assessment. In my interview, I look for any patterns that fit the picture of peripheral sensitization, bearing in mind that the inflammatory process of a fracture or a cancer have the same effect on nociceptors as does a sprained ankle. So I try to rule out serious pathologies using information from the interview while also testing the tissues, including the somatosensory nervous system. And I find it equally relevant to consider the consequences of both negative and positive findings in these tests. Ideally, this will help me rule out pathologies, including cancer, fractures, infections, rheumatological diseases and nerve damage. And once all these so-called red flags have been ruled out, I can treat the pain according to the neurobiological mechanism. In the case of peripheral sensitization, this would mean leave it alone. What I would do is give the patient a narrative explanation of what I think is the cause of the pain, along with some information about active rest, about sleep and restitution, and some information about how not to provoke the pain. While in the case of acute pain there is somewhat predictable associations between nociception and pain, the opposite seems to be the case for longer lasting pain. Once pain persists or is recurring over a period of 3 months or more, it is by definition considered chronic. Unlike what some patients and many clinicians think, chronic does not mean that it's uncurable or that the patient is sentenced to a life in misery. It simply means that we must change the way we deal with it. Admittedly, the word chronic is less than ideal from a semantic view, and also perhaps because the general understanding of the word is not what it's really meaning. But bottom line is, it doesn't matter what we call it, but it does matter how we deal with it. Clinically, chronic pain often misses a clear pattern, making it much more complex to understand the mechanisms behind it. Recently, the term nociplastic has been introduced to provide a reference to unspecified neurobiological changes in the nervous system. While central sensitization is one candidate for a mechanism that leads to hyperalgesia and possible allodynia, it is not a stable feature of the intact nervous system. On the contrary, it seems that our nervous system is under strict control and capable of making radical changes when necessary, only to return to homeostasis once it's no longer provoked. So in short, central sensitization should not be considered the cause of chronic pain, and as a consequence, don't treat central sensitization, treat the patients. What does seem to be the most common features of chronic pain are the stories that the patients tell. These include how pain interrupts their lives, how interference from the pain cannot be predicted or controlled, and how pain influences their mood and social relations, including work. As is the case for chronic pain, there are clinical tests that may assist your diagnosis and treatment even in the absence of a clear mechanism. These include spreading of the pain within one or more regions of the body, some dynamic sensory tests, as well as information about specific functional and social limitation that the pain has on the patient. The patient's beliefs, expectations, and previous experiences with treatment as well as with pain are also relevant. However, unlike acute pain, where so-called psychosocial factors and yellow flags may predict prolonged pain, this is already the case in chronic pain. Thus, they could be relevant targets for treatment when the patient considers them to be part of their overall disabilities. Bearing in mind that cognitive therapies and psychoeducation are effective treatments without any known side effects, they're still no good without the active participation of the patient. The same goes for physical activity and exercises. Once we accept that rehabilitation or management of chronic pain is different from treatment of acute pain, the tricky thing becomes to understand when to stop treating and start managing or rehabilitating. In my view, too many patients are treated with marginally effective treatments for far too long. Besides being a waste of time and money, ineffective treatments may keep the patient away from managing their life situation while they wait for the magic of X, Y, or Z treatment to kick in.